The hat I've got on today is part of the trial management group for PPAC2, which allows me to change on to my most favourite of conversation topics, which is bottoms. So I'm going to talk to you about our trial. So we are currently recruiting. We're a trainee-led, multicentre, randomised controlled trial, looking at the impact of packing post-operatively of perianal abscesses. Now, I've already had several discussions with a few people here that they find these patients quite difficult. They're slightly different from your normal is a relative term, but they're a slightly different group from normal wound patients. They're often much, much younger. We are running this out of the Northwest Research Collaborative, which is a group of surgical trainees and consultants, all with the aim of doing more research and audits. We also have research for patient benefit funding for this trial, so that's been adopted onto the NIHR portfolio. Wouldn't be complete without aims, so I'm going to take you through the process that we went through with PPAC2. So from the initial idea to where we're up to now, and that's my plan, with the aim of sort of talking through any of the barriers that we had to the trial itself. They may also mimic any problems that you may have with any other wound-based trials. So, as I say, talking about bottoms. So, perianal abscesses, so cryptoglandular abscesses, are common. They're not as common as your leg ulcers that you've heard from today, but again, they're a much younger population. So, the idea behind these is that they occur from blockage of some of the mucus-secreting glands that sit around your anorectal junction, and that causes the abscess. And these can track either internally into the anus, so you might not see anything in the outside world, or they can track along the tissue planes, and that's when you get these very painful swellings around people's bottoms. Current management is incision and drainage, as I'm sure you guys all know, and then they are extensively packed in the community, often with people requiring sort of multiple pack changes a week for several weeks until they've completely healed. Now, the old school idea behind this is that packing them stops the skin from healing over the top. That stops you from leading a potentially infected cavity underneath. The idea thinking that if you leave a subcutaneous or even a deep ischiorectal cavity, that you can increase the rate of fistulas or recurrence. But there's actually no evidence that that's the case. So, we wanted to do a randomised controlled trial looking at whether packing of perianal abscesses was worth it. The first barrier that we came across was the fact that there is actually no evidence for current practice at all. So you don't even have enough to inform a proper randomised controlled trial. So there is a Cochrane review out about this that was published before we did the feasibility study, which I'll talk about in a minute. But that found 2 studies, the total of which have 64 patients, both of which were significantly underpowered, both of which changed halfway through how they were looking at their wound healing. Now, overall, they hint at the fact that packing may increase the rates of fistulas and reduce the rates of recurrence. But as I say, it's a hint in underpowered studies in low volumes. What do we do with that? So, this raised the question. So, is packing of perianal abscess cavities necessary? Would not packing them and just putting simple dressings over the top be better? And what information is currently available to inform best care? Now, I've already talked to you about that. Basically, none. So, we did PPAC, the original. So, we did a feasibility study. So, this was 15 centres across the UK, and we recruited 141 patients. I won't insult your intelligence by reading through the slide. Of significance to us as clinicians was that there's a 27% fistula rate at 6 months, with a recurrence rate that's quite low, about 7%. You will also notice at the bottom, more because I've put it in the middle and in bold, that there is a significant cost in terms of dressings and in terms of community nurse time. And you guys don't need me to tell you this, and I know it's already been discussed this morning, that perhaps if we were to do something different, this time, this money may be better spent. So through this trial, as I say, from our 15 centres, 95% of patients were packed. There is a centre, I think Cambridge, someone will correct me, I'm sure, but that do not regularly pack their perianal abscesses, and there is nothing wrong with that because there's no evidence that it works. So it was just news to us when we were running a study. We also asked patients to fill in lots of information about pain, and what we found was that when patients are having these packed, and I'm sure you know better than we do, being the ones that do all of that work, is that there's a 2 to 3-fold increase in pain scores when patients are having them packed, and that pain doesn't really go away for the first 7 days post-operatively. Now, as an interesting aside, we've spoken to lots of pain experts when we've been attempting to set up the randomised controlled trial, and there is a lot of information about surgical pain post-operatively, and there is evidence that even for minor procedures, that increased post-operative pain at day 5 is a significant risk factor for post-op chronic surgical pain. Now, that was something that we hadn't asked before, is are patients with perianal abscesses actually getting chronic pain, and nobody's looked into it before. We also gave our patients diaries, we ran focus groups, basically to ask them what they think about it, to then set up a further trial. What we found, and I'm certain this is no surprise to you, is patients absolutely hate packing. It's really painful, as we've already discussed. It's also really inconvenient for them. So we're looking at a younger working population. They often have to take a significant amount of time out of their current work life. The other thing to say is that they find it really expensive. So if patients pay for their prescriptions, and a lot of this group do, they are paying for their dressings. The other thing, and I've already discussed about the considerable cost, both financially and in terms of community nurse time to the NHS. So we then moved on to planning a formal RCT, and here comes barrier number 2, is what should be our primary outcome. So we're a group of clinicians. What's most important to us is healing, fistula rates, recurrence, as I've already discussed. But actually, patients don't care about that. What they care about primarily is that pain. So although PPAC, the original PPAC was just an observational study trying to look at healing, PPAC 2 has been run with the aim to look at pain. Our secondary outcomes are, as we discussed before, like the quality of life stuff. I know you've already discussed sort of the E5D quality of life scores. We are also going to have a look at recurrence and fistula rates for these. PPAC, the original, has allowed us to power the study, and we're going to need 526 patients, so recruits, over 24 months, and for this we'll need a minimum of 20 sites. So the primary endpoint, we know it's pain. Again, I'm sure it's no surprise to you that measuring pain is a subject for much discussion. You could write many books on it. So there were 2 questions with this. How do we score pain? And when do we score pain? So the simplest response is that you score pain when they're having the abscess packed. But obviously, for one group, you're not going to have that same insult. So that was somewhat difficult. So what we settled on, along with patients and along with experts in pain control and measurement in trials, was that we would have the most wound-related pain over 24 hours, measured on 100mm VAS score. And that would be averaged over the first 7 post-operative days. We're also going to have a look at quality of life, and as I said before, rate of wound healing, evidence of fistulas, and we do have some chronic pain scores for later on in the study as well. We're also going to collect any information on current pain management use, because obviously that's a significant confounding factor. So, this is the trial design. So, coming into your acute surgical unit, you'll have patients with primary perianal abscesses, and these will be eligible for entry. So, criteria that will mean patients are excluded is patients that are less than 18, if they've got a history of inflammatory bowel disease, because they're at higher rates of fistulas and they're higher rates of recurrence, and any evidence of things like Fournier's gangrene or horseshoe abscesses, because we know that these patients need quite extensive resections sometimes. They will then be counselled through sort of what the trial's going to involve. They'll be given a patient information sheet and any time that they want to ask any questions. And they will have their incision and drainage as normal. And most centres, in fact all of them, all include a haemostatic pack at the time of surgical procedure. Post-operatively, the patients are then randomised and consented for the study. Now, the reason that it was decided that they were randomised post-operatively and consented is A, because you don't always know what you're going to find intraoperatively, but also we wanted to be as pragmatic as possible. There are lots of different incisions that different surgeons will use for treating this. We didn't want somebody to change their surgical approach based on what group they were going to go into post-operatively. So they're going to be randomised into either packing or non-packing, and the randomisation is 1-to-1. Follow-up for both groups is the same. So they have a patient diary with those pain scores, as I've already discussed, quality of life scores, any information about current pain control. And they fill that in daily for the first 7 days, and then at day 14 and day 21. They'll also have a telephone consultation at day 7, mostly to see how they're getting on, any other problems, but also to see things like when they go back to work, which is obviously, as we discussed, very important for this group. We will then do a 4-week clinic review. Patients will come to our clinics. They will be assessed, which will be blinded by the nurses in clinic. So they will remove the packing, remove any dressings, and the clinician in clinic, only after that has happened, will go in and have a look at the wound. If they've healed at 4 weeks, then they have a telephone consultation at 8 weeks. If they've not healed at 4 weeks, then they go back to clinic again at 8 weeks. And at 6 months, everybody is seen in clinic to assess fistulation. At 1 year, we aim to get the hospital statistics data to see about any recurrence or any other treatment that they may have had at a different centre. So, where are we up to? So, as I said before, we're RFPB funded. We've got REC approval, which was completed in January 2018, and I'm sure any of you who've run clinical trials know that that was substantially after the date that we'd originally expected it to be. Our first centre opened February this year, and hot off the press today, we have 16 centres open with six patients recruited. We aim to complete August 2019. So we're currently staggering the opening of centres. As I say, the aim of this is to get trainees involved with studies as well. So it's easier for us to manage if that we're staggering the opening. We have feasibility forms in from 50 centres across the UK, and the aim is to open as many of those as possible. And that's me, I think. So any questions or anybody that wants to be involved, the best person to contact is Rachel Dagnall, who's our PPAC2 trial coordinator, or any of us at the trial management group. We will be absolutely happy to talk to you. Any questions?
Hello, Alison from Accelerate. A question about stents. Is this something that's done when someone is has a recurrence of fistula, or do you have stents put in automatically at all in any of your patients?
Do you mean cetons?
Cetons. I always call it the wrong thing. Sorry,
no,
cetons.
Okay.
Yes.
So often you will find that when you're doing a perianal abscess, incision and drainage, they may have a fistula as part of their original disease. But quite often in treating the abscess, the fistula itself can go away. Now there's variation in practice throughout the UK, but the majority of centres will treat the abscess primarily, so we'll do that incision and drainage, and then we'll put in a ceton later down the line if there's a fistula. Okay. Recurrents are very difficult. Now, we're not actually including so dramatic recurrent abscesses in these. Often they do need more extensive sorts of management. They're the people that tend to involve needing MRIs and things, but actually they're not the majority of these patients by any stretch. Okay. Does that help?
Yeah, thank you.
Any other questions?
Hi Jenny, just a quick query really. Post-operatively, if you're not opting for packing in one group and you're on the other, how are you going to eliminate the intangibles of the clinical intervention for cleansing the wound, whether they're using antimicrobials or using some kind of PHMB or whatever, because that's going to influence potentially the healing rates of them?
So this is one of the difficulties that we had with setting up PPAC, was that there is such, as I'm sure you guys are aware with any of your wound management stuff, there is such a considerable variation in practice that you have to draw the line somewhere between letting people continue with their current management and you running your trial appropriately. The honest answer is that we've set it so that actually we don't give any stipulations for the people that are not dressing, they're not having their wounds packed. It's up to the community nurse or the practice nurse discretion, whatever they would normally use. Most of the time, as far as we're aware, there isn't that much use of antimicrobial creams and things for these, but there is a section for the community nurses to fill in, and in fact leaflets for the community nurses as well, so that we know exactly what they're doing. So the honest answer is, we know it's a problem. If the study finds something, that we'll have to take that into account either way anyway. We're recording it, but we haven't set specific guidelines for the people that are not packing. We want it as pragmatic as possible, same as with the incisions that we haven't stipulated.
Lovely. Thank you very much, Jenny.